Again, my name's Seth Hale. I'm one of the interventional fellows at UT Southwestern. Thank you so much for having me here. So, kind of an interesting case, a case of chest pain from an unlikely source. So we had this 74-year-old guy present to an outside hospital. He had a complaint of chest pain, progressive past week in setting a volume overload, had typical signs of heart failure. His pain was somewhat atypical. He had some exertional components to it, but sometimes it also occurred at rest. And he also states about 1 month ago he was admitted for staph aureus sepsis, and that's really when his chest pain had started. So his past medical history is significant for super morbid obesity. Actually, is the new term for it. BMI greater than 50. He actually was just shy of 400 pounds. Type 2 diabetes on insulin, ischemic cardiomyopathy with an EF at 32%. He had a prior one-vessel CABG in 2012 after a failed PCI to the proximal LAD. He had 6 sinus syndrome, hypertension, ILD, AFib and Eliquis, and Lynch syndrome. So a CTA aorta was done because he also had just some sort of descriptions of maybe this like radiation, crushing type chest pain, etc. And so what was interesting is he has this very large aneurysm actually originating from the left anterior descending artery, was what the initial read was. So we tried to look at it on echo, really couldn't see it. The windows were exceedingly poor. We were in the echo lab for 30 minutes just trying to visualize this, but it was unfortunate we were not able to. So diagnostic angiography, you can see here there's the RCA. Large vessel gives off, maybe it was a large vessel, it won't play that well. But it gives off a PDA and an RPLV. And then the lima, patent, you can see it backfills all the way to the proximal LAD, filling the first and second diagonal branches as well, consistent with a CTO diagnosis. And really, this amazing aneurysm that was just sitting there actually measured 4 by 5 centimeters, coming right off the left main based on IVUS. It's right at the bifurcation, right when the left main comes off. And you can see it's stealing dye from the circ as well. So the real next question that we had is, why does this guy have chest pain? Kind of thinking about it, there are 2 real possibilities. One, the more likely is that he's having embolic phenomenon. This thing is so large, you can see the circling there. He's just kind of forming small clots here, and they're raining down the coronaries, kind of giving him intermittent NSTEMIs, which is really what he ended up presenting with. Then the second would be thrombotic, maybe a complete occlusion, but again, I think the more likely reason for that is that is this large aneurysm. So now we kind of looked at how do we close this, and there is a paucity of literature, to say the least. A single case report actually of a 4 millimeter LAD aneurysm where they used a stent to cystic coil embolization, but nothing to this magnitude. But then if you look in the peripheral literature, there actually are quite a few case reports on closing these with peripheral coils. So what we ended up doing was we engaged with an EBU wire. Our EBU guide, we ended up wiring the circ. We ended up wiring into this large aneurysm, used IVUS to confirm our placement, and then we placed 1 small peripheral coil. And if you kind of see this coil, intermittently, right as we release it, it starts to sort of tumble. But as we continued on fluoro, this thing started rolling around this giant aneurysm. It was a very scary moment, to say the least. So we obviously weren't getting the thrombotic propagation that we were wanting with that, so we ended up placing a larger peripheral coil. This is actually a 10 by 30 centimeter interlock at 18 peripheral coil, which seemed to sort of do the trick. But one issue that you can see, sorry, this is sort of buzzing here, is that on this injection, it's pretty notable that now you have no flow in the circ system, right? So you're trying to start thrombosis. Sometimes you get to reap your own rewards there. So we went ahead and closed this with a papyrus stent first, because we knew that our first goal was going to be close the aneurysm that has thrombus in it already, and then try and deal with what you have left. So really we ended up passing an aspiration catheter, adenosine, tropoban, and the tincture of thyme. It was really scary to put this guy in tropoban with this large aneurysm, but after we knew that we had closure, we felt good about it. And eventually we were able to get this to close off, which is great, even though there we go. And so you can see the flows returned, TIMI3 flow, and all as well. So patient was discharged to the ICU, stable condition, actually went home in post-op day number 2. 3-week follow-up, he remains chest pain free. Etiology of this is a little more interesting. These are very rarely described. We did a vasculitis workup. That was all negative. We had infectious disease because he had this like staph. Is this like a mycotic aneurysm? They actually didn't think so. ESR, CRP were very low. They didn't feel like it was truly infectious. Obviously, closing off an infected mycotic aneurysm in the coronary seems high risk, to say the least. Then the other question was prior wire trauma versus like a plaque rupture with destabilization. He had that failed LAD PCI in 2012, so perhaps that was the cause of it. And really the interesting thing about this, to our knowledge, is the first case of a coronary aneurysm closure via a radial approach and the use of peripheral coil. And so thank you so much for letting me come up here not once but twice.
Great case, Seth. One thing is you're worried about the coil going around in this aneurysm. This is where stent-assisted closure would be helpful. You place a stent in the circumflex first and then pass through the stent, and then you're free to send coils, and your stent will protect the circumflex from having clots or coils go down in it. The other thing, you could have started from the beginning probably with a covered stent, but you have to justify that to the IRB and a lot of paperwork to fill. It's not approved for that indication. Any other comments?
I would echo for many folks that have done the coil assisted, the stent usually in place. I think here the coils were so big that probably would be lesser of an issue. But I think if you're using smaller coils, having the stent in place is going to prevent you from those coils coming back up. The reality is, just to echo your point, is like there is a huge positive data on the natural history and management of this issue, whether it's surgical, observational, anticoagulation. And I think the issue is how rapid is that aneurysm, progressing in size, and the size itself of it. But it seems like pretty good size. I think it was a very good approach.